My name is Dr. Shri and I am the doctor today. So I just checked, are you his son?
Yes.
Okay. So I just checked him. Can I ask you some questions regarding him?
Of course.
Okay, so how old he is?
He is 75 years old.
Okay, does he work?
No, he doesn't work.
Okay. Where does he live?
He lives in India, Sadar, Betul Bazaar.
Okay. What he's complaining about pain and all?
Yes, he has leg pain in his right leg.
Okay. Does he complaining about anything like vomiting or fever?
Yes, he has vomiting sometimes.
Okay. How many times he vomit?
He had vomited, I think 2 times.
Okay. Does he feel like normally or having some appetite?
No, he is not feeling hungry.
Okay. Do you know when the pain started?
Yes, pain has started 3 weeks ago.
Okay. Does he went to doctor?
No, he didn't.
Does he take any medicines?
Yes, he took inflammatory.
Okay. Did he had any trauma?
No.
Okay. Did he have pain in the other part of the body or only in the leg?
No, only in right leg.
Okay. In his childhood, does he has any problems?
No.
Okay. Does he has any gastric cancer?
No.
Maybe blood infusion?
No.
Okay. Does he smokes or take alcohol?
No.
Okay. Does anyone of his family had myocardial infarction?
Yes, his parents, but not him.
All right. Does he have had diabetes?
Yes.
Okay. He did any operations?
No.
Okay. Does he had stroke?
Yes, it happened 2 years ago.
Okay. Thank you so much for this information. We will do some examination and we will let you know. And if I need, I will again talk to you.
The general condition of the patient is severe sun look older to his age and the consciousness is affected. The posture of the patient is passive. The head of the patient is in normal shape and size. There are no deformities. The mucous membranes looks dry and the ears are in normal shape and size. Neck of the patient is in normal shape. There are no enlargement or swellings. The skin turgor is decreased, which suggests dehydration of the patient. The musculature of the patient is well developed and bones are in normal shape and size. The nails have normal configuration. The skin of the patient is pale and yellowish and the patient has low-grade fever around 38.3. The condition of the patient is severe according to the Glasgow scale. The patient score is 11. He looks older to his age. The skin of the patient is greyish yellowish in color. The mucous membrane is dry and the patient has temperature around 38.3 degrees. The patient's chest is symmetrical and the respiratory rate is increased and the rhythm is irregular. The breathing is noisy and dyspnea is present. On percussion in upper parts, the lung resonance is clear, but in lower parts there's dullness. And on auscultation, the vesicular breathing is normal, but in lower parts we can hear pathological wheezing and crackles. The patient has shallow and noisy breathing. The patient also has tachypnea and dyspnea. There is dullness in the lower parts and also wheezing and crackles are present in the lower parts, which all suggest there is dysfunction of the respiratory system. The apex pit is palpable at fifth intercostal space with very weak amplitude. The pulse of the patient is very low and irregular. On percussion, the left border absolute and relative cardiac dullness is detected, upper border absolute cardiac dullness is detected, and right border absolute and cardiac dullness is detected. On auscultation, the patient heart sounds are very muffled and the patient heartbeat is increased. The blood pressure of the patient is 90/60. The inspection shows that patient has cardiac dysfunction with tachycardia, hypotension and hypovolemia. The abdomen looks normal. There is no pain, no local tension, no tenderness of the abdominal muscles, and there is no hernia or visible peristalsis of the stomach and intestines. And the liver is palpable and increased in size. The spleen is also palpable and looks normal in the size. During auscultation, no peristaltic sound or ventilation is heard. The tongue and the mucous membrane of the oral cavity is dry. There are no abdominal sounds present, and the size of the liver is increased, which suggests hepatomegaly. And the distal rectal examination shows blood from the anus, and all these signs shows the dysfunction of the GI. The inspection of the genitourinary system shows there are no swelling, no protrusion on the lumbar and the suprapubic region, and on palpation all the points are painless, and the urinary output of the patient is decreased. The urine is dark yellow in the color and there is no blood present. The inspection of the nervous system shows there is weakness in the arm and the leg of the left side due to the stroke suffered 2 years ago. The inspection of the right leg shows that the color from knee till foot is black. There is no sensation present. There is tenderness and tissue loss. On palpation, the pulse is absent at femoral, popliteal, posterior tibial, and dorsal pedis point.
After diagnosis, we got that he has a gangrene on his right leg. Okay.
The primary diagnosis suggests that the patient has gangrene on the right leg with lower GI bleeding, left side hemiparesis, severe sepsis, septic shock, and multi-organ dysfunction syndrome. Lab findings indicates liver dysfunction, kidney dysfunction, hyperglycemia, leukopenia, high ESR, low RBC, hemoglobin, thrombocytopenia, glucosuria, lactic acidosis, arterial hypoxia, hyperventilation. We can conclude that the patient has multi-organ dysfunction syndrome. There is dysfunction present in the respiratory system, cardiovascular system, hepatic system, gastrointestinal system, renal system, central nervous system, hematological system.
The final diagnosis states that the patient has arterial thrombosis, which led to the gangrene of the right leg. Patient is on NPO because patient is unconscious and unable to eat, so it should be given parenterally. Antibiotics are good to administer as it kills bacteria in the infected area, such as carbapenem. Anti-inflammatory agents should be considered to relieve pain. Hypobaric oxygenation is essential to treat gangrene as the tissues are deprived from oxygen. Oxygen therapy is also needed due to respiratory dysfunction shown by the patient. This will be done through nasal catheter. Inhalation therapy such as antiseptics and bronchodilators are used. Mucolytics are also considered. Surgery in this case would be amputation. Foley catheter needed to check the urine output. Without knowing the urine output, it's hard to control or monitor infusion therapy. Carbon dioxide and oxygen monitoring need to be done, as carbon dioxide will be higher in this case compared to oxygen as a rule. Central venous access is used to ensure fluid infusion will be faster and in a larger volume. It can also be monitored properly. Correction to anemia and hemostatic system is obligatory and done with the transfusion of red blood cells and platelet for anemia. Clotting factors may also be missing as a result of MODS, which is corrected with cryoprecipitate, FFP, and vitamin K. At 11 a.m., the patient has arrived and surgery is considered at 1:30 p.m. Pre-operative preparations will take place between that time frame. In this chart, it shows the amount of fluid being administered hourly. Normal saline is indicated here for fluid loss and hemorrhage in this patient. Dextrose 5% is given for nutritional support as patient is unable to eat on her own. Lactated ringer is given for water and electrolyte loss in patient due to its low blood volume. Red blood cells, FFP, platelet given to support hemostatic system. The total volume of fluid administered would be 3.25 liter. When vital signs and lab test is checked, we would know how severe the blood loss is, which is why the amount is not large because the patient needs to be replenished before surgery. Based on the urine output seen and monitored every hour, we would know how much fluid needs to be administered.
During infusion therapy before entering surgery room, the vital signs are to be monitored together with urine output. And as you can see on the table, vital signs has slightly changes but still need to be monitored from time to time.
The chart above concludes the conversation between the doctor and the relative. Amputation will take place 2 hours after admission and above the right knee level. Local anesthesia will be given because general anesthesia will suppress the already failing respiratory system. The anesthetic used could be bupivacaine, which is used 2 to 3 ml, lasting for 3 to 4 hours. The chances of success rate is low because patient has multiple organ failures and different pathologies such as bleeding. Thus, it is important for the doctor to ask the relative if the surgery is allowed even though there is a low percentage of survival. In this report, the date of surgery is confirmed to 28th of May for the patient who is weighing 70 kg with a height of 170 centimeter. This is necessary to calculate infusion therapy. The surgical site will take place at the right thigh. All laboratory tests have been done. Everything in the oral cavity should be absent as it could cause asphyxia during surgery if inhaled. Contact lenses should be removed and jewelry should be removed and taken by the relatives. Makeup should be removed to check up for the color of mucous membrane, and lipsticks should also be removed to check if cyanosis is taking place. Nail polish to check for refilling time. Clean patient gown, cap, and sanitary pad are used for aseptic technique. Blood is needed as well as pre-anesthetic medication such as atropine or dromedrol. Foley catheter is attached for void. Shaving done 2 hours before surgery. GIT fasting is not needed as patient is already on NPO. Enema is also not needed for that reason. And nasogastric tube is needed due to NPO. During surgery, these medications are not needed because bupivacaine have been injected and it would be enough for the patient. Local anesthesia is much safer to do compared to these options.
Here's the management of how the surgery will be done at 1:30 a.m. Step 1 is we do surgical access, fishmouth shape incision made above the knee 10 cm from tibial tuberosity. Step 2, surgical maneuver, cut through fascias and muscle layers. Hemostasis, divide femur using saw, remove necrotized part, edges of femur bone fill. Step 3 is wound closure. Flaps with underlying layers are used over stump to close with absorbable sutures, and hemovac drain is placed.
Infusion therapy will still be continued during the surgery, and the vital signs will continue to be monitored until expected goals are reached.
As you can see on this table, vital signs slightly change, but maybe we can change infusion therapy rate and also monitor the reaction of antibiotics given to the patient for stabilization of patient during surgery. As you can see on this table, it shows how some antibiotics react to some gram-positive or gram-negative bacteria. So for this patient, we chose carbapenem, piperacillin intravenously, 4th generation cephalosporin, and metronidazole intravenously. The reason to why we chose these antibiotics is because these antibiotics have broad spectrum to kill gram-positive and gram-negative bacteria.
After surgery, patient will be transferred to post-anesthetic room, and for post-operative monitoring day 1, patient is on diet MPO, and then for patient's position is supine, and patient will be given anti-embolism stocking until 1:15. After that, will not be given, and then for deep breathing or coughing, no. Heat application, no. Cold application, only until 1:15. After that, no. Patient doesn't have back rubs, and for antibiotics, analgesic, insulin, and anticoagulant will be given. Medication given is 4th generation cephalosporin, metronidazole, insulin intravenously, ibuprofen, tapered dose of heparin intravenously for prophylaxis of thrombosis. Vital signs are continued to be monitored, and as you can see on this table, patient has high pulse, high respiration rate, low blood pressure, and consciousness GCI is also low, and his temperature is higher, and the skin is pale. As you can see on this table, vital signs still getting worse despite intensive treatment on second day. Patient still has septic shock. Antibiotics therapy should be changed because before maybe the antibiotics therapy didn't change. Urine output is close to 0, which is anuria. For the next few hours, patient is unstable. Vital signs shows indicator for septic shock. We will tell the relative that the patient's condition is getting worse and not responding to any medications. Nothing can be done to save her, and doctor will explain that sepsis has high mortality rate and that she came in late. We'll give the best medical treatment, but it wasn't enough. Patient time of death is 16:13. If patient has cardiac arrest, CPR should be done unless patient has DNR. Chances of restarting activity of the heart in this patient will be low.